uterine bleeding. Usually, when we say dysfunctional uterine bleeding, it's part of what we call abnormal uterine bleeding. Normal uterine bleeding, it's when you have irregular uterine bleeding, simply could be more blood, different intervals, anovulatory bleed, breakthrough, anything cause abnormal uterine bleed, something different than the menstrual cycle. Now, what's the DUB? It's bleeding without any demonstrable cause. So we don't have a cause. Now, when we say we don't have a cause, doesn't mean there's no pathology, but we are not able to identify it. And those where we say dysfunctional uterine bleeding. Now, what's the regular ovulatory cycle? Ovulatory cycle, remember, we have proliferative phase, where you have a build of the endometrium, we have the secretory phase, and then the menstrual phase. And that's the regular cycle. So the hormones which secreted from the ovaries goes to the endometrium. It works in preparing the endometrium for menstruation. And that's where you see a regular fashion, cyclic, predictable, almost consistent, timing and amount of loss. And that's usually what we call it regular ovulatory cycles. The hormones we're referring, once you start FSH and LH act on the ovary and make the oocyte go bigger, we start seeing the estradiol grow up. And that's elevated estradiol in the first few days of the menstrual cycle. We calculate cycle day 1 with the menstruation. Around the mid-cycle, that's the highest estrogen level. And then you start seeing the LH surge where the progesterone starts to grow up in the second part of the cycle. So LH surge and led to increase of progesterone in green. So when you start with your estradiol going up. This high estradiol will trigger the LH surge in blue. LH surge will make the corpus luteum now giving more of a green, which is progesterone. So the proliferative, where the endometrium gets built, and this under the effect of the estradiol. Once you have this LH surge with the ovulation, the progesterone will come from the corpus luteum, and then it change the composition of the endometrium. That's where the secretory phase. And if there is no pregnancy, a demise of the corpus luteum led to the drop of both estradiol and progesterone, and then the menstruation occurs. That's when you have a regular ovulatory cycle. Now, when you don't have ovulation and ovulatory cycle, that LH is flat. So when you have that flat LH, your estradiol will gonna be flat. You have some estradiol activity, but not in the same fashion we've been seeing there. And the progesterone is very low. So if you compare this estradiol going up slowly with the days peaking, inducing LH surge, led to ovulation, lead to high progesterone. With this, where you have estradiol continuously flat, a little bit elevated but flat, and the LH never come up, no progesterone. So the endometrium, you will see it in a different way. You see an endometrium with thickening due to estradiol, so more proliferative, but it never goes secretory because you will never see progesterone. Now, this what we've been saying about the effect of the hormones on the endometrium. So the ovarian cycle, which with the growth of the follicles need to growth of the estradiol, it build up the endometrium, and that's the proliferative phase. And the ovulation occur. Now start the ovary in yellow here, building up and secreting progesterone, will change the structure of the endometrium and make it ready to implant. If there is no implantation, no pregnancy, there will be demise of corpus luteum, no more hormones, led to the shed of the endometrium in the menstruation. And that's a regular menstrual cycle. This cycle will not be seen in case if you don't have ovulation. When you do ultrasound, that's exactly what you see, days of the cycle. Day 5 of the menstrual cycles, the follicles start to grow. You see the endometrium is very thin, will be like 3-4 millimeter. By day 9, with the more growing of the follicles, you see thickening of the endometrium. It becomes like 6 millimeter, 7 millimeter. By day 14, the maximum thickening of the endometrium in the proliferative phase, and that's you're going to see about could be anywhere 8 to 14, 15, because that's the highest, and then the ovulation occur. When the ovulation occur, the progesterone now will start to come, and you see change in the composition. Now the secretory phase, more of the glandular glycogen secretion of the endometrium. If the implantation occur, so that's the fertilized ovum, blastocysts, implantation occur, it will continue as a pregnancy. If there's no implantation or no fertilization, the corpus luteum will die, and then this lining will be thin and shed as a blood, and that you'll get the first day of the menstrual cycle. You see the blood coming from the basement of that, okay? Now, in case of implantation, that's a different story. This blastocyst implant and give more of HCG, which the HCG will lead to the more of life to the corpus luteum. It stimulates the corpus luteum to continue giving progesterone and the hormones needed. And that's what's going to help in the sustainability of the endometrium to build the blood supply for the placentation. So the normal menstrual cycle usually, which is ovulatory one, it's from day 1 to day 1. So from first day of bleed to the next bleed, it's about 24 to 35 days. The older you are, the shorter the menstrual cycle. And this shortening comes from the time of the follicular phase, which is the proliferative phase. Usually, the luteal phase is stable unless there's illness of 14 days. The anovulatory cycles, or certain people with polycystic, they will have prolonged cycle. They will have 40 days, 45 days. Up to 35 days is acceptable. Duration of bleeding, 4 to 6 days is usually acceptable, maximum 7 days. Average volume, 35 cc, okay? And that's being measured by weight. So we said, in order to have a regular menstrual cycle, you need to have a regular ovulatory pattern, which is any deviation from that led to a deviation from regularity of the menstrual cycle. At the same time, we need to have a normal hemostasis. Hemostasis, it has 3 arms in the uterus. One, you have vasoconstriction, and you have the thrombi formation with a platelet plug, and you have the myometrial contractions. So those 3 cause hemostasis. Any disruption of these mechanisms lead to more bleeding, lead to abnormal menses. So Abnormal uterine bleeding, either we're dealing with irregular interval, could be shorter, could be longer, or could be there's no bleeding. I mean, it could be oligomenorrhea or amenorrhea. All of these are causes of abnormal uterine bleeding. Or it could be irregular flow, a lot of amount, lots of clots. Instead of 4 to 6 days, you might have 10 days, 12 days. So length of that. Timing. And she can bleed at any time. She can bleed today, bleed after 1 week, bleed after another week. So intermittent spotting. So all of these count with the abnormal bleeding. Now, what's menorrhagia? Menorrhagia, it's prolonged or excessive uterine bleeding that occur at regular intervals. Or more strictly, the loss of 80 cc or more of blood per menstrual cycle. So if we say you have a longer cycle or you have an excessive cycle, so could be days, could be amount. Both of them, they calculate for menorrhagia. At the end, they're losing more blood. Metrorrhagia is irregularity of the bleeding time, especially we can say it's bleeding between periods, or they could go with this month having 20 days, next month having 40 days cycle. Polymenorrhea is frequent menstrual bleeding, most strictly menstrual bleeding that occur every 21 days or less. A shorter cycle. Menometrorrhagia is defined frequent menstrual bleeding that's very excessive, irregular in amount and duration. But these terms, you find them in the textbook. In reality, mainly menorrhagia is the one who's really heavily used, metrorrhagia and menorrhagia. And the oligomenorrhea and amenorrhea. And those were the absent cycle. So you don't have a cycle except once every 2 months, once every 6 weeks, anything more than 35. And if it goes to more than 3 months, it's amenorrhea. Some people put the postcoital bleed as separate entity, which is simply bleeding or spotting after intercourse, and some people would put it with the metrorrhagia. Now, what's the problem? The problem, it's very common. I mean, we're seeing menorrhagia as very common. And with a common problem in the community, it leads to a lot of disruption in the schedule of people, their life quality. Some people lead to anemia, debilitating. Some people, they need blood transfusions. So a life quality, and in certain cases, seriousness of need of blood support and transfusion led to a lot of people to start to understand and try to understand what's the pathology there. Unfortunately, in around half the number of the cases, we don't know a pathology, and thus are the DUB. So before we come and say it's a DUB, we have to look for this differential diagnosis, and that's very important slide. Remember, dysfunctional uterine bleeding or DUB is a diagnosis of exclusion. So before I say that is the diagnosis, I have to be sure that all of this table is rolled out. So I'm sure that there's no endocrine causes like anovulation. So she is having ovulatory cycles. And I'm sure that there is no medical problems in the coagulation. There's no let's say, the hemostatic arm. So we don't have von Willebrand disease, we don't have any platelet abnormalities, and we don't have iatrogenic causes like they're taking warfarin or enoxaparin, which is a cause of bleeding. And they don't have systemic disease. Like certain people, they might have systemic diseases which affect their ability to have the normal hemostasis, especially on the liver functions and hepatic formation of the fibrinogen and the clotting factors. The other common arm is the anatomical factor in the uterus, which they led to, if you have uterine fibroids, like this, lots of fibroids. You see these blobs, it's leiomyoma. It's a benign, but it gives two problems. Number one, you have, if they are inside the cavity, like intracavitary, that means they prevent a normal contraction, and at the same time, they give a higher volume of endometrium to bleed. The same for others. I mean, others, presence there, they prevent a normal contraction of the uterus and make the size of the uterus bigger, so it give higher volume of endometrium, give higher volume of bleed. Endometrial polyp, on the other hand, is when you put the hysteroscope and you see a tiny polyp inside the cavity, and that has, again, to prevent the contraction, and it gave a higher exposure of endometrium. Now, other cases, adenomyosis, where you have the endometrial glands inside the muscles of the uterus, and those give bigger volume to the muscles of the uterus, and those are very difficult to treat because they are not for surgical removal, and they don't shrink easily with medical therapy, and give a bigger volume to the uterus and bigger endometrial surface and more bleeding. Now, other cases, if you have any cancer or hyperplasia, or if you have infection, usually when we look at areas of infection, could be in the endometrium or in the cervix. And if we look at the area of neoplasia, if you have a tumor that's inside the cavity, that could be benign and could be cancerous. Like this picture, it's clearly cancerous, and you take a biopsy and it will show you endometrial cancer. That's all causes of abnormal bleeding. You can have intracavitary myomas, and usually we resect them with a scope. So if you have a pathology in the cavity, the best treatment is surgical treatment. We control them surgically. We remove the myomas or polyp either by open or by resectoscope from down below. And if they have cancer, it has to be taken for biopsy, like in this picture, and sent for pathology. And in pathology, it's a treatment removal of the whole uterus and some type of lymph nodes. Now, all of these, now we made the diagnosis. They are not DUB. All of these cases, we give a cause of bleeding. So if they have an infection, you treat the infection. If they have anatomical cause, treat the anatomical cause surgically. If they have a hemostatic problem, you need to treat according to that. Usually we give tranexamic acid, or if we have a factor to replace, we do factor replacement. And if they have endocrine causes like anovulatory bleed, we try to regulate them with hormones. And if they don't have any of these, we end up with a diagnosis called dysfunctional uterine bleeding. So they have clear symptoms of menorrhagia, of abnormal bleeding, And in the same time, we did not find any clear cause. So before we put them in this category, we have to be sure that that list we've been discussing and showing all this picture being excluded. So that's all the secondary causes being excluded. So it's very important to establish a diagnosis. So it's a diagnosis of exclusion. So take a good history from the woman, good physical examination, and do good workup. We have to consider age groups. So when you get a young lady, young girl, you might 13 to 18 years old, is not uncommon that you will see an ovulation. And that's physiological. In the same time, and that's an event. So you see the girl has a period every 2 to 3 months, and that's maturation of the system. And that's part of the physiological. I wouldn't put a big weight in it. That's something usually she grow it out. You might need to support her with, from time to time with some hormonal, but usually mainly progesterone, but usually they don't need a lot. Just reassurance. Or if they have von Willebrand, congenital causes for abnormal homeostasis. And that's where we need to be sure that this is diagnosed early and treated. Now, the reproductive age women, which is 39 years old, usually they have PCOS, usually. And function, stress, exercise, weight loss, which led to this. Now, the late reproductive age, above 40 till menopause, usually have a lot of anovulatory, and we would like to be sure that we're not dealing with cancer, okay? And that's where you can see the risk of endometrial cancer and need for endometrial evaluation. It makes more with increase the risk with increased age, because that's our main worry. Now, if you have an obese woman and she has an anovulatory cycles, because that's obesity is a risk criteria, unopposed estrogen risk criteria, not response to medical therapy, probably we need to do an endometrial evaluation, take a biopsy, do biopsy, and be sure that you are not dealing with cancer, especially above 40 years old. Now, before we call it dysfunctional uterine bleeding, we have to be sure she is a real DUB. Rule out all other factors, especially cancer or hyperplasia. And then we go and decide the goals. What's our goal for treatment? Are we going to cure her? No. Usually you cannot cure because we don't know the cause. But we try to control the symptoms and improve the life quality. Right. That's one. Two, decrease the risk on the long-term complications. So we want to be sure she does not have acute bleed, which led to blood transfusion anemia. We want to improve her life quality by prevent future episode of non-cyclic bleeding. We would like to decrease the risk of long-term complications of the anovulation, like unopposed estrogen. And this unopposed estrogen will lead to hyperplasia and cancer. So we have to reduce it. So we, at the end, we reduce her health risk and in the same time improve their life quality. What's been suggested as a management in the literature? No single fit to everyone. So we have to do more customization for patients. So how old is she? So if you have somebody who's 13 years old, you don't want to give her high dose estrogen, so you close her bone, okay, and affect her height. So if she's, again, 45 years old, maybe high dose of hormones not good for her. She's at increased risk of DVT. And what kind of medical status she has? Does she have a lot of complications? She is known to have thromboembolic disease. She has comorbidities, diabetes, and really how much of amount of bleeding is severe. Does she really drop her hemoglobin each time? Does she go to ER? Or just a subjective feeling and is tolerable, not affecting her quality? Again, does she really want to become pregnant? I mean, there's no point that I give her treatment which does not make her pregnant and improve her symptoms, and really her life quality goes that I would like to be pregnant. So all of these make you have to customize the management according to the patient's situation. So the choices, we can use progesterone or any progestational agents. Usually they do well, they improve the cyclic of the patient with DUP, and the complication rate is low with them. They use it for 2 weeks, 12 days to 14 days per month, and then stop. They're going to have a period. Or you can give injections. You can give injections of progestin, like medroxyprogesterone acetate. We give it every 3 months, and that's reduce the flow and improve a lot of the symptoms. Some people like all contraceptive pills, which has a very good role in certain patients. And that's really, for me, this is number one in a young woman I use. The other one is the Mirena. I use the IUCD, which has a progesterone, and I put it in to really improve the life quality. I mean, it depends, as I said, on the patient, what she wants. But the most commonly used two things is the progestin, especially intrauterine device, Mirena, which reduce the flow, improve the life quality, and there's lots of literature accumulated on that. The second one is OCB. Now, in acute bleed, sometimes we use estradiol, high-dose estradiol, just to fix and repair the endometrium in a quick fashion. Some people, they've been using non-steroidal to reduce the flow, and that's really effective, especially if it's associated with pain. Some people, they've been using naproxen a lot. It's fading away with time, Salaha. Mefenamic acid being used a lot, but it's fading with time. More now antifibrinolytic, which is transchemic acid. I mean, a lot of people, if they have heavy period, they give them during the cycle transchemic acid. We use it. Other people, we use danazol, like androgen steroids, especially for the adenomyosis, and rich agonist, especially for the fibroid and adenomyosis. Now, the surgical, I mean, in case of acute cases, rarely you need to do dilatation and curettage. Rarely. I don't like it. It does not help all the time. Sometimes it helps, but it's really risky one. I mean, in certain cases, you need to do endometrial ablation, where you go by hysteroscopy and burn the endometrium. That's for older age group. She's not interested to become pregnant above 40. She's really completed her family. And you really just will go ablate the endometrium and solve it. It's take half an hour procedure. The hysterectomy, this is the other one, is just they remove them. And that used to be very highly done in Western societies before the introduction of the endometrial ablation and before the introduction of the IUCD Mirena. IUCD Mirena improved the symptoms amazingly and reduced the need for hysterectomies in a major volume of patients. Now, the endometrial ablation, people, they like it. And unfortunately, a third of the patients will still have bleeding. At least they require hysterectomy in 5 years, and that's in a large prospective data. So, what would I recommend for DUP? A, make a good diagnosis. Rule out secondary causes. B, I would go number one with the easiest medical therapy, OCP or ICD marina progestin. Now, a woman who failed medical therapy and she does not want any more kids, she's the one candidate for more surgical treatment like ablation or hysterectomy. Now, we can go through a few cases if you want, but I think let me go through questions and see if we really would rather go through cases or not. Okay. Do you have questions? Hello? Do you hear me?
Yes, sir, we can hear you.
Yeah, you have questions?
No, thank you, doctor. It's all clear.
Now, let me run a couple of questions for you. If you, I'll just pick randomly. Do you have Renad?
Yes, doctor, I'm here.
Yeah, Renad. So if you have 15 years old, come to you, and you're in the clinic, and she's complaining that she had a period every 2 to 3 months.
You said she's 15 years old, and we said that this could be physiological.
Good girl. So you would reassure, right?
Yes, reassurance.
Excellent. Thank you. Reem.
Yes, doctor.
Right. Reem, you are in the clinic and you got a 15 years old, but she got her period every month, but really heavy with a lot of clots. And when she brushed her teeth, she got some gum bleed. What would you do?
Coagulation test.
Excellent. So you will screen for von Willebrand for platelet function assay, right?
Yeah.
Be sure there's no major systematic clotting factors problem, صح?
Yeah.
Good. Mohammed. Mohammed. He's not there, okay. Amjad. Amjad. So those two people are not here, okay. Abdussalam.
Yes.
Yeah, Abdussalam. You've got a lady who is 30 years old, and she's been having heavy period. She will bleed like 9 days a month, and she has a regular cycle. It comes on a time every month, but come for 9 days and some clots. You've done all the workup and it's negative, no pathology. So what do you think her diagnosis?
What do you mean by 9 day a month?
She got a period for 9 days.
For 9 days?
Yeah, bleeding 9 days with blood clots. What's her diagnosis?
Progesterone.
Huh?
Progesterone. little.
No. She got every month exact timing. كل يوم 28 من الشهر she got her period. But start bleeding, it continue for 9 days bleeding. And she passed a lot of clots. وكل الورك اب حقها كان negative. What's her diagnosis?
uterine dysfunction ولا ايش؟
والله ما ادري، انت كنت مفروض معانا في الليكتشر، ما ادري يعني. لينا امجد. Is somebody قريبة؟
Yes, doctor.
Okay, Shahad, did you hear my question?
Yeah, she's 30 years old. صح?
Okay.
About 30 years old.
So
Yeah.
what's the diagnosis?
I think since we did all the workup and we didn't find any causes, then would it be DUB? Because
Excellent.
everything's
Excellent. See, at Salam, that's the clear diagnosis. Everything is negative. So she does not want to have kids for the next 3-4 years. And then she might consider having kids after that. What would you suggest for her treatment, Ya Shahad?
hormone replacement, like hormonal therapy.
Excellent. Like ish.
Progestin.
Excellent. So we can put IUCD Marina, right? Progestin.
Yes.
Okay. Excellent. Or oral contraceptives. Excellent. That's the first line. Type. So who's the moderator here today? Who's your teaching assistant?
It's me, doctor.
Type. You've heard we've called few names and they are not here. Okay.
Okay.
So
Okay.
you have to take care of this attendance. Okay.
Okay, sure.
Then they're not here. They have to be calculated for the attendance. Okay.
Sure, yes, doctor.
Okay. Thank you. Have a good day, guys.
Thank you.
Bye.
Thank you, doctor.
Bye.